Hello and welcome to AU Manufacturing Conversations, where we explore the people, policies and processes shaping Australia's manufacturing future. I'm Simran Gill, and on today's episode we're discussing a critical healthcare issue that highlights Australia's pharmaceutical manufacturing vulnerabilities. In late February, I reported on a serious shortage of benzathine benzyl penicillin G, or BPG, an essential medication used to treat syphilis and prevent rheumatic heart disease. These conditions disproportionately affect Aboriginal and Torres Strait Islander communities, making this shortage not just a manufacturing concern, but a serious health equity issue. Today, I'm joined by three experts who recently published a paper in the Medical Journal of Australia addressing this very issue. Dr. Rosemary Wyber is a general practitioner and researcher focusing on cardiovascular health of Aboriginal and Torres Strait Islander individuals and communities. Associate Professor Lawrence Manning is an infectious disease physician and researcher based in Perth with expertise in antimicrobial pharmacology, among other areas. And Associate Professor Glenn Pearson is the Director of the First Nations Strategy and Leadership at the Kids Research Institute Australia, located on Whadjuk Noongar country. Welcome to all of you, and thank you for joining AU Manufacturing Conversations. It's great to have you here today.
Thank you.
Yeah, it's great to be with you. Thanks.
Morning.
Okay. So, Dr. Wyber, let's start with the basics. In your paper published on Tuesday, you highlight the shortage of BPG. Could you explain what this medication is and why it's so important?
Yeah, absolutely. So BPG is an acronym for benzathine penicillin G, and it's a really old antibiotic invented in the 1950s. But what's special about it is that it provides really long-lasting penicillin in the bloodstream. So it's a poorly soluble salt, and that means that when we inject it, it's given as an intramuscular injection, that it lasts a really long time. And that's a really special thing because it means it can be used for things which either need to be treated with a long duration of penicillin in the blood, or things which are intended to prevent reinfection, so it's prophylaxis. And it's a really established product that we've known about for decades now, but it's been a really challenging product to get hold of. In fact, there have been shortages in Australia for decades now. And so that's had a real impact on the conditions that we treat with BPG, which are both prophylaxis for acute rheumatic fever, preventing the development of rheumatic heart disease, and also the treatment of syphilis infections. So it's a pretty significant drug for Australia to be trying to muddle through without.
Okay, moving on, Professor Manning, from a clinical perspective, what does this shortage mean for patients? I understand there are some alternative formulations available, but they come with significant drawbacks. Is that correct?
Indeed. The formulation that we currently have registered in Australia is one that's called Bicillin LA, and that's been manufactured by Pfizer in the US. It comes as a pre-filled syringe, which has a relatively small volume of around 2 mils. It's probably the best currently available preparation, but it still hurts when you give it as an injection in the muscle. But during the most recent stockout, the TGA provided what's called a Section 19A exemption for the importation of a different powder preparation to cover the shortages. And these powder preparations require mixing with an extra bit of water. So you have to have a vial of powder preparation, you add water, and it ends up being about double the volume of the pre-filled syringe. The downside of that is that it has to be given through a larger needle as well. So the powder preparations that have been used to cover the shortfall are really inconvenient, and they hurt more than the pre-filled syringes. And actually, what the powder preparations in lots of other countries in the world, the healthcare workers actually refuse to give the injection because it hurts so much.
So what is that on the pain scale? What would it be likened to?
Well, I guess each individual has a different experience of pain. What our patients tell us is that it hurts for a long time and they really hate having their injection delivered. Indeed, what actually happens is that for patients with rheumatic heart disease, they often report pain out to 3 days after the injection. And the pain is so bad that it limits what they can do on a daily basis. So they can't play sport, they struggle to go to school, they struggle to even lie down and sleep. So it's on the pain score, it's a bit hard to provide a general value, but actually the impact on people's lives is pretty severe.
Okay, Professor Pearson, could you help our listeners understand why this medication is so important for Australia?
Yes, certainly. So if we build off what Lawrence has shared, so you're a mum or a dad, you've got a bub that needs to travel long distance to the clinic to go and get that painful secondary prophylaxis treatment every 28 days for, on average, up to 5 years, possibly longer, to stop the possible reinfection of ARF into a RHD. You can imagine what that must feel like, both for the child, the young person, their parents, in terms of their family. It's quite a traumatic experience for them. And it's not only in terms of that experience, but they live compromised lives as a consequence of this affliction. Unfortunately, it's a global pandemic in terms of the impact of rheumatic heart disease and syphilis, particularly around Maori and Pacific Island communities and African countries. And in Australia, it's predominant across Northern Australia. Not only, but predominantly across Northern and Central Australia, both in terms of rheumatic heart disease and syphilis. So in the case of rheumatic heart disease, it's 100% preventable, but in the absence of clear and defined and purposeful interventions, and they are being assembled, particularly through NUTCHO in collaboration and partnership with the Australian government and state and territory governments, we are left with this option in terms of trying to prevent RF to RHD, for example. And so it becomes quite critical when you think about that the PPG that we want over the alternative, which Lawrence pointed to, is quite critical.
One of the things I found fascinating about your paper was the detailed breakdown of the global BPG supply chain. Professor Manning, could you walk us through why Australia is vulnerable to these shortages? I understand there are 4 manufacturers of the active ingredient worldwide.
At a global level, BPG is sort of a really salient example of global market failure for what is essentially an essential medicine. On the demand side, most people with rheumatic heart disease and syphilis live in low and middle income countries where government investment in healthcare is really low. The existing powder preparations hurt, and healthcare workers don't like delivering it, and treatment completion is poor. On the supply side, as you say, there are only 4 manufacturers of the active pharmaceutical ingredient, or API. 3 of these are in China and 1's in Europe. Only one of these produces the API under good manufacturing practice, and they're the ones that provide the ingredient for the Pfizer preparation, which we use in Australia. There are also really inconsistent price signals across the world. So in low and middle income countries, powder preparations cost between 20 and 40 cents per dose, whilst in rich countries like the US, a single vial might cost $300 or more. So what this means is that the API producers of most powder preparations have no financial incentive to manufacture an additional product, which leads to really inflexible product cycles and minimum order quantities and really global erratic procurement. And that results in shortages. At the other end of the spectrum, for Pfizer, their product is highly profitable, but there are no alternate markets willing to pay, and there's little incentive for them to invest in expanding production or improving the formulation. So in answer to your question, Australia is vulnerable to shortages because we rely on only one manufacturer with only one API producer. And presumably, due to the price differential between the US and Australia, the US market gets prioritised over markets in other markets like Australia, New Zealand and Canada.
And Dr. Wyber, back to you. This isn't the first time we've seen shortages of BPG in Australia, is it? Your paper mentions stockouts dating back to the early 2000s. Is this a recurring problem, and what's been done in the past to address it?
Yeah, look, I think this is one of the really challenging things about the recurrent shortages of BPG in Australia. So there's been documented stockouts in the early 2000s, and then a prolonged stockout between 2006 and 2008, and then supply chain disruptions and concerns about shortages globally across that time period. And I think that really highlights how vulnerable we are as a country to interruptions in supply and the inability to access alternate products in a timely fashion to really meet needs. We've gotten better at that as a country over time. So the Section 19A exemption from the Therapeutic Goods Administration, really realising and identifying that shortages are coming and that we need to be taking action to secure alternative formulations, and some work that the Commonwealth has really invested in to make sure that pharmaceutical manufacturers do need to forecast and provide notification of upcoming medication shortages. That's all been really helpful, and there's been real leadership from across the health sector, and particularly the community-controlled health sector, to manage and provide information and communication to frontline service providers about how to deal with stockouts. But the fact of the matter is, if Australia just can't get this medication, we simply can't manage our way out of the problem. We really need to be looking at sustainable alternatives to be able to access this essential medication in a way that is really robust to changes in the global market.
For all our listeners who might not be familiar with pharmaceutical manufacturing, what makes BPG particularly challenging to produce? Is it a matter of profitability, technical complexity, or something else entirely?
As I said earlier, there's actually no financial imperative for either the producers of the powder preparations or Pfizer, who produce the pre-filled syringe, to expand production or improve the existing preparation. And there's been this widespread perception that a generic formulation or a new formulation would never be profitable. But at a manufacturing side of it, and penicillins are a really tricky beast to deal with, particularly BPG, because it can be difficult to produce. And regulators are particularly concerned about the potential for cross-contamination between various sites. And the consequences of cross-contamination is the concern about allergies to penicillin. So what that means is that when you try and make a penicillin, you actually have to have a completely standalone facility, which is hermetically sealed for every other product line that you have in your facility. And so that really means that the capital investment you need right at the beginning is quite large, because you can't use that facility necessarily for anything other than antibiotics.
So let's talk about what's happening right now. Professor Pearson, your paper highlights the role of the National Aboriginal Community Controlled Health Organisation in responding to the current shortage. Could you tell us about those efforts, please?
Yeah, thank you. And as Rosemary highlighted just in her previous response, NACCHO represents the voices of 146 Aboriginal community-controlled health organisations across Australia, and particularly where syphilis and rheumatic heart disease, or ARF, is present in the Northern Australia. They are our front line in terms of primary health care, but increasingly more so across the full spectrum of Aboriginal and Torres Strait Islander life, and particularly their ability to be able to mobilise and get very quickly into incredibly diverse spaces across exceptionally large areas of land. And I'll give you an example. The Kimberley region, it's about twice the size of Victoria. It has a population just over 20,000 Aboriginal people, and through the leadership of Vicky O'Donnell as the CEO of CAMS, and to the member services, the ACHOs across the Kimberley, they are able to, through their local services and into their clinics and in partnership with the state health department, able to reach into the lives of families in that regard. So they play a very critical and a highly sophisticated role in responding to the needs of our families. And so their ability to be able to support their teams on the grounds to be able to prepare and respond is exceptional. The challenge, however, is the two options that are on the table, and including the problem of stock out. So they're prepared, and the trade-off is that if we don't have the quality of medication that we need, then they're going to have to touch things several times in order to get the one thing to happen. And that's an incredible waste of good resource into places that are dealing with really high complex needs. So there is unfortunately a demand. We just need a really good supply.
So could you please tell me what the effects of the stockout have been?
So we don't have any really good data on the specific effects of this stockout because it's happening in real time. But what we know is that this uncertainty about access to supply is a real headwind for service providers trying to deliver BPG injections. And as Glenn indicates, that's particularly an issue for Aboriginal and Torres Strait Islander people having these injections every 28 days to prevent worsening of rheumatic heart disease. And that's already difficult enough to deliver and to receive. And having to think about, is the product going to be available? Which formulation will it be? Has it got to the right clinic today? To make sure that clinics are distributing product to the places they need to be across vast geographic regions, and the stock supply chain management for this problem really makes an already very difficult problem considerably harder. So what we know is it's not helping efforts to end RHD in Australia, and it's causing a considerable workload across the health workforce, which is really adding to an already very significant burden.
And just to add to that, although it's not an Australian example, we know that there's good evidence that when you have stockouts of BPG in other settings, it's certainly been associated with massive increases in the rates of syphilis and syphilis transmission, which leads to congenital syphilis in young children as well. So although we don't necessarily have the data here, there's good evidence globally for the impact of BPG shortages. And for us working in this space, I think the stockouts have really laid bare the difficulty with trying to provide this medication, which is high quality, and it's really laid bare the global inefficiency. So it creates the opportunity for us to start building the case for us to actually have sovereign manufacturing in Australia.
I noticed that you keep making references to syphilis. As someone who's not from a medical background, and perhaps some of our listeners won't be, could you quickly explain what syphilis is and why it's a concern, I suppose, and how severe or maybe not severe it can be?
That's for you, Lawrence.
So syphilis is a sexually transmitted disease that's been with us for many, many centuries. It causes a variety of manifestations. So after the initial infection, you can get a sore on the genitals, which generally goes away. But if it's not treated, it can lead to secondary and tertiary syphilis, which affect the brain and the heart most commonly. The sort of public health imperative for the importance of syphilis is really about, it's also associated with maternal to child transmission. So when you're pregnant and you happen to have the syphilis bacteria in your body, it can transmit to the child. And that can cause a number of manifestations. It can cause stillbirth, preterm delivery, and most importantly, congenital defects, so malformations, which sit with the child for their entire life and represent a huge burden to both that child and also the community. So when we talk about treatment, we generally give, for the BPG, we give an injection in the muscle on day 0, and then 1 week later, and then 1 week later. So there's 3 consecutive doses given a week apart. And the treatment completion rates for that are really low. In some settings, they're less than 10%, largely because the preparation is so poor and people hate having the injections.
Thank you for explaining that. So this podcast is called AU Manufacturing Conversations. So I'd like to focus on the manufacturing aspects now. Your paper makes a case for developing sovereign manufacturing capabilities for BPG in Australia. Dr. Wyber, what would this entail, and is it feasible?
It's eminently feasible for Australia to choose to locally produce BPG to meet the significant domestic needs that we have in Australia, and as a regional and global contribution to tackling some of these really important conditions and to secure global supplies of this product. What it really takes is political will and commitment to make this happen. We've been managing shortages of BPG in Australia for decades now. We've unfortunately become better and better at it. But at the end of the day, if we don't have access to high quality product with reliable supply, we can't do what it takes to tackle rheumatic heart disease and syphilis in Australia, nor can we support the efforts of our regional Pacific neighbours to do the same, and nor can we be part of a global solution. Australia has the capacity and, unfortunately, a significant need to be able to access this product. And the way to make that happen is to produce it locally.
Professor Pearson, how does this proposal for sovereign manufacturing align with the national priorities for closing the gap and addressing health inequities?
Very easily. I think the primary architect of the Closing the Gap agreement, Pat Turner, who is also the CEO of NACCHO, in the wisdom of the drafters of the Closing the Gap agreement, not only laid out a series of targets over the life course of Aboriginal and Torres Strait Islander families to work in partnership with government and the NACCHO services, or all of the Aboriginal community organisations, and with the community more broadly around a resolution of those complex challenges across the life course. but in her wisdom also identified 4 priority reform areas, which is a call out to mainstream Australia and particularly national, state, territory governments and organisations such as the Kids Research Institute, to what I have framed those priority targets as leaning in to the effort, leaning into the leadership, leaning into coming together and working together around these complex issues, whether they're global or national, regional or local. We have clearly recognised that working alone won't do it. We need to rally together because we can't continue to turn up at the opening of each parliament of each new year, giving the next iteration of the closing gap targets, which appear to be standing still with little increase or going backwards. I think what is also happening more broadly within the world, particularly in the changes that are happening within some of the politics, I think Australia's been sweetly reminded that there are a requirement for us to establish our own space and place and abilities, particularly post-COVID, to be able to take care of our own. As a very isolated country, I think there's also other stronger imperatives from a national interest to pursue this as a clear and purposeful outcome for not only Aboriginal and Torres Strait Islanders, the Maori communities, the Pacific Islands more broadly, but then for us as a country.
Professor Manning, your paper references recent innovations in delivery methods, including subcutaneous rather than intramuscular administration. How might local manufacturing capabilities help advance these innovations? And did I say those 2 words correctly?
Well done. So, yes, our team in New Zealand and Western Australia have been working on the safety and efficacy of delivering subcutaneous, and that is an injection under the skin rather than in the muscle, which is intramuscular, to patients both with rheumatic heart disease and with syphilis. And what we've shown is that in the trial settings anyway, that the subcutaneous administration hurts less and the penicillin concentrations last longer. So what that means for patients is that instead of having a monthly intramuscular injection, we can deliver a high dose of subcutaneous BPG and it lasts for up to 10 weeks. And similarly for syphilis, instead of having to come in 3 visits, we can do the entire dose at a single visit. And in both scenarios, patients say they prefer this rather than the existing IM preparation. So when we think about that in terms of manufacturing, having that subcutaneous administration listed on the brochure and the product information sheet as an alternative route of information would be a game changer for patients with rheumatic heart disease and syphilis, and would certainly smooth out integration of subcut administration into both national and international guidelines. And in the setting of the Australian context, having subcut administration included as a characteristic would differentiate it from pretty much every other product available in the world.
Are there any other relevant examples of sovereign manufacturing in Australia?
Yeah, look, Australia's made a real commitment to strengthening a domestic pharmaceutical industry. There's been significant investments around mRNA vaccine scale-up, particularly around the COVID experience. But most recently, there's been an announcement in the last couple of weeks about a commitment to scaling up our domestic production of saline, so salty, sterile water that's used for a whole range of medical indications, and for which there has been a global shortage for some time now. Australia's really identified that having locally available and locally produced saline is critical to be able to develop and provide essential medical services. And so what we've seen from the Commonwealth commit to is matched funding to private investment in this space to scale up at the Baxter production facility. That really demonstrates that when Australia has identified a priority with strategic importance for the country, it is possible to secure funding and investment and political will to bring that to fruition. And I think that has really strong parallels with the significant priority need for BPG, particularly given the influence of Aboriginal and Torres Strait Islander people in this country.
If we were to develop sovereign manufacturing capability for BPG, what would be the first steps? Who needs to be involved, and what kind of timeline might we be looking at?
I think the first step is having the political will to actually commit to embarking on this project. Without that, and certainly political contribution, as we saw with the saline example, is what's required to galvanise the private sector to also be engaged. It's clear that for BPG, we're going to need a standalone facility. And as I said earlier, you can't actually have product lines of penicillin adjacent to other product lines for other medications. And along those lines, we also need to have a clear product development plan to build our own generic formulation, sort of similar to the Pfizer preparation, or, and this is my preference, is to actually make it better than the Pfizer preparation, make it more injectable, make it a smaller volume and less painful. And to do that, as part of that, we need a clear pipeline for TGA approvals. All these things need to come together before you actually have a product rolling off the shelf. And it's a long process and it's expensive.
Your paper mentions other medications that have faced shortages and particularly impact Aboriginal and Torres Strait Islander people. Could you give us a couple of examples, please?
Yeah, absolutely. Look, some of the things we talked about in the paper include the use of permethrin cream, which is for treatment of scabies, an antibiotic called azithromycin, which is for treatment of wet cough, medication for treatment of trachoma, and diabetes medications, all of which are really important for managing conditions with a disproportionate burden for Aboriginal and Torres Strait Islander people. But excitingly, there are some examples of where a broader approach of sovereign manufacturing and engagement with the global market has provided opportunities for Australia to show leadership in some of these essential medicine categories. Lawrence, those are areas of your domain.
Yeah, so the example that really springs to mind is the fantastic work that Medicines Development for Global Health, which is an Australian-based not-for-profit, has done in establishing moxidectin and getting FDA approval for this drug. And moxidectin has a whole broad range of indications which are both relevant internationally, globally, and for the Australian market. So in the Australian context, it's going to be a really important drug for scabies. But critically for West Africa and the rest of Africa, the rollout of moxidectin is going to have this amazing impact on a disease called river blindness or onchocerciasis. And the critical part about this is that it's been done and been led by an Australian not-for-profit, where what they've done is they've taken a drug where the global market environment is such that nobody's prepared to develop it. They've acted as the sponsor to develop that particular drug. They've gone through all the regulatory approvals, and now they're rolling it out. And they're not making a loss on it. It's done on a cost-plus basis so that places in rich countries who can afford to pay a little bit more, pay a bit more, and countries where there's really urgent need don't pay as much. And so it's really a fantastic model on which to base BPG.
If you could deliver one message to policymakers or industry leaders about this issue, what would it be?
Basically, I believe we need a serious commitment from both local, state and federal government to galvanise the private sector to help build a new BPG for Australia.
It is absolutely possible for Australia to choose to make BPG available for communities in this country who need it, and to decide that we will be a regional and a global leader in producing this essential medicine. What it will take is an investment, political commitment, and a choice by this country that this is important. It's an area where we can be a leader, and it's something we've chosen to commit to.
And building off Lauren's and Rosemary's responses, this is a global challenge and it has a critical Australian heart to it. And so I think we've got to go for gold on. I'm pressing on this matter. I think it's the compromises that are made for the reasons that are being explained to here have a human cost. And unfortunately, the most vulnerable in the Australian community are the ones who are paying the prices of that indifference. And so we've got to rally around this opportunity to get it right for the reasons that we've laid out in this conversation today. The lesson of the referendum is that nothing should proceed without us. We've been on the receiving end of other people's views about how our world should be, and inevitably they've been constrained to the Aboriginal part of us, but we are both Australian citizens and we require an appropriate response to this Australian issue.
Thank you so much to you all for taking out the time to give us your insights on something that's obviously so important.
Thank you.
We've covered a lot of ground today, from the clinical importance of BPG and the impact of its shortage to the complex global supply chain issues and the case for developing sovereign manufacturing capability here in Australia. What's clear is that this isn't just a manufacturing issue. It's a health equity issue that directly affects our ability to meet national targets for closing health gaps and preventing preventable diseases. I'd like to thank my guests, Dr. Rosemary Wyber, Associate Professor Lawrence Manning, and Associate Professor Glenn Pearson for sharing their expertise and insights today. Their paper was published in the Medical Journal of Australia quite recently, so feel free to check it out. If you'd like to read more about this issue, you can find a link to both the paper and my earlier coverage in the show notes. Thank you for listening to AU Manufacturing Conversations. If you enjoyed this episode, please subscribe to our podcast and join us next time as we continue to explore the future of manufacturing here in Australia.